Okay, so let's get started. Hello, everyone, and welcome to the Population Studies Colloquium organized by the Population Studies Center and the Population Aging Research Center. Before I introduce our speaker today, a couple of reminders about the technical aspects of the colloquium. Today's presentation will be recorded, live streamed, and disseminated via the YouTube channel and other social media of the Population Studies Center. If you may have noticed that your video and audio are turned off, this is intentional, so don't be alarmed. Please submit all your questions in the Q&A tool. At the end of the talk, I will call upon you if you have posted your question with your name, and you will be able to ask the question in person. You can also ask questions anonymously. In this case, I will read the question for you. We would like to give preference to questions from graduate students and postdocs. So if you are a student or postdoc with a question, please indicate so in the Q&A box. For us as organizers of the PSC Colloquium, it has been particularly important that we provide also the opportunity for researchers who are in the beginning of their research career to present their work to a wider research community. And it is my greatest pleasure to introduce our speaker today, Aashish Gupta. Aashish is a PhD candidate in demography and sociology at the University of Pennsylvania. His research focuses on health, environment, and social stratification in developing countries, and has been published in the Economic and Political Weekly, in Population and Environment, in the Journal of Environmental Economics and Management, and in the Population Research and Policy Review. Aashish was awarded a Civil Registration and Vital Statistic Fellowship by the International Union for the Scientific Study of Population. Aashish, welcome. We are very happy to have you as our presenters today. And now over to you.
Thanks so much, Ileana. Thank you. So thank you for joining this talk on social disadvantage and life expectancy in India. In this talk, I will present a couple of related papers and some of them with co-authors. So, and you will see that this is very much a larger research agenda. So even if you think that there is no hope for me, your comments would be really helpful for my co-authors. They may also drill some sense in me as I move forward with this research agenda. So just to give you an outline, I will talk about the measurement of life expectancy in developing country context and existing research on social disadvantage and mortality. Without a lot of background, I'll jump right into the first paper, which presents a general approach using data from the demographic and health surveys to document the relationship between social disadvantage and mortality. For this, I will use a question on deaths in the household plus the birth history module that is available from the DHS surveys. And then I'll apply this, the life expectancy estimates, to generate life expectancies by household wealth in India over a long period, sort of the period since I was born until 2016. And then a second application is social group disparities in life expectancies in India. This is joint work with Nikhil Sudarshanan, and this is where these related papers really started. And a second and related project, I will talk about explaining these disparities using the annual health survey, which is a survey that was conducted in 9 Indian states in 2010 and 11. This is joint work with Sangeeta Vyas at the UT Austin Population Research Center and Payal Hathi at Berkeley Demography. And so what we do is we standardize group differences by economic status and calculate accurate standard errors. I will finally summarize with larger implications. I also discuss implications of each of these specific things in the middle. but the broad conclusions are kept towards the end. So, just to preview some of the findings, I hope to convince you by the end of these contributions that we are able to generate reliable estimates of age-specific mortality rates and period life expectancies. And we also develop a methodological approach to cluster bootstrap confidence intervals from complex survey data for any life table quantities that you are interested in or demographic decompositions that you're interested in. And substantively, we document large disparities by social and economic status in India. This is work on social disadvantage, particularly in the adult ages, has been mixed. So there have been Nikhil's work, for instance, shows more modest gradients than in more developed contexts. In India, we still find steeper gradients than other comparable developing countries. And then finally, we see social group differences are not explained by differences in economic status. Hopefully, you will agree that this is what I have been able to do. So, just by way of background, so to calculate life tables or period life expectancies, we need estimates of age-specific mortality rates. So say in between ages 60 to 65, these many people were alive in a particular year, in a particular place, and these many people died. Now, this relies on counts of death, which come from civil registration data, and people, which come from censuses. Uh, and so these counts of deaths and people uh, are available for developed countries over a long period of time and form the basis of harmonized data sets such as the human mortality database. The big challenge is that a large number of countries are absent from the human mortality database. The majority of people are absent from this database because civil registration is incomplete in many developing countries. That is, not all deaths are registered. In fact, in some developing countries, even censuses are incomplete. So there are survey estimates, which typically are for a subset of the population. So think of the demographic and health surveys, which provide estimates of child mortality. These surveys are called the National Family Health Surveys in India. There have been 4 rounds of these. Think of health and demographic surveillance sites, which for localized populations, particularly in sub-Saharan Africa, these continuous monitoring sites provide vital estimates across the life course. Think of studies like the health and retirement study and an increasing number of related studies from developing country contexts, which have been used to study adult mortality in a variety of contexts. And think of the sample registration system. Now, the sample registration system is basically one way to think of the SRS is a nationally representative panel of HDSS sites. The sample registration system has been functional in India since 1970 and is also available from some other Asian countries. Now, we typically, demographers have studied the reliability and the extent to which, and the strengths and limitations of these variety of approaches. And we typically think, we know a whole lot about what are the various problems in various data sets. It is easy to think that there are no problems in developed country context, although Irma, for instance, would remind you about age misreporting among older Black people in the US, which biases mortality estimates for at the oldest ages among marginalized populations in the US. My friend Yana would tell you about how misreported education is on death certificates. It is useful to remember that there are minor differences between life expectancy estimates between, say, HRS and NHANES studies and civil registration deaths within the US. Now, what happens if you don't have this information available or have information available only for some ages in some contexts? A large contribution of demographers has been to develop indirect estimates, for instance, from model age patterns of mortality or for survivorship based on multiple census data. There is a third approach which relies on survival of relatives by respondents. So what in this approach you do is you can ask about the survival from people who are currently alive. In a survey, you can ask about the survival status of relatives. So there is the orphanhood method. There is the sibling survival method. Depending on who you are talking to, this can either be called direct or indirect estimates. The main thing to recognize is that there are biases in estimates of mortality from these survival estimates. I will use a variation of this approach, which is the household death question. So, for instance, in the National Family Health Survey 4 in 2015 and 16, in the household roster, this question was asked: did any usual member of this household die since January 2012? If any member had died, there were follow-up questions on sex, age, month, and year of death. This question was also implemented in the first round of the NFHS, in the second round of the NFHS, and in the annual health survey in 2010 and 11. This question, you can go to ICOMS and see that this question has also been implemented in other censuses in various countries. But past work should make us really skeptical of this question. So Ken Hill, in a classic paper written in 1991, says, in practice, the household death approach has given very disappointing results for both child and adult deaths. The standard textbook in demography, Preston, Hubeline, and Geo, says such procedures have yielded less success. This evidence is based on surveys available in the 1990s and analysis done till then. So now surveys are larger, maybe they're better. So perhaps there is a case to reevaluate this skepticism. So what I do, my goal is to estimate deaths in person years to estimate mortality rates. So for adults, I use this household reports of household deaths within the household in the in the recent period. And so I create a lifeline for each household member who has died. So basically, say a survey was conducted in January 2015 in NFHS 4, an interview was, and then a person died in January 2014. So let's say the observation window starts in January 2013. So for this person, I will create a lifeline January 2013 to January 2014, a year of exposure. For alive members, these are observed in the household roster. So in the household roster, in surveys, people list all the members of the family, their age and sex, and then I create lifelines starting at age 5. For ages below 5, that is for children, I use the very standard birth history module, and I create age-specific mortality rates using standard demographic approaches. This is much more familiar to people. And so we obtain age-specific mortality rates in the observation window. What is this observation window? We use last 2 years in the survey, and we can also use other, like 3 years, we can use yearly estimates. The life expectancy and mortality rates change slightly, but basically changing the observation window does not change the results substantially. I will catch a breath, and you can read these other methodological notes till then. Okay, so and then now these mortality rates that we have obtained, they are from complex survey data that use the multi-stage sampling design. So to quantify uncertainty, we need standard errors and confidence intervals. So we use an approach that has been developed for, say, multi-state life tables. In developed country context, there's a paper by Ezra Fishman, a Penn demography graduate from 2015, that I found very useful in this. So basically, we repeatedly sample primary sampling units since the surveys were implemented so these primary sampling units are villages, and these were randomly selected, after which respondents were randomly selected within these primary sampling units. So I basically pick from the survey a random sample of primary sampling units, and then I create within each bootstrap sample, I create life expectancy estimates. So I draw 100 bootstrap samples, and then this is a complicated way of saying that the standard error is just the standard deviation of these 100 life expectancy estimates. And I assume that the estimator for life expectancy is distributed normally So 95% confidence intervals can be calculated by the standard, like life expectancy plus 1.96 into the standard error, plus or minus. And then we are able to quantify uncertainty for any life table quantity that we're really interested in. So what do we get? Now this is these are like age specific mortality rates and life expectancy estimates uh, from the sample registration system. So these are sort of India's national life tables. And then from NFHS 4, we find that the two surveys are very close to each other. Typically, the big concern in using survey estimates of mortality is we will underestimate mortality and overestimate life expectancy. Here we see that the life expectancy estimates from the NFHS are actually lower than the SRS, and same patterns, I mean, similar patterns for male and female. I have this graph for the second round and the first round of the NFHS. Also, if you're interested in, we find the same thing. So now we have estimated specific mortality rates and life expectancy at all ages. You can do what you are interested in from these data. So whatever the DHS measures or whatever can be matched to the demographic and health surveys, we can use these to examine the determinants of mortality in developing countries. What do I do? So one application is I'm interested in this classic question: do rich people are rich people less likely to die? So I create a household wealth. I apply this to get life expectancy by household wealth quartiles. So as Amartya Sen likes to remind us, this is a fundamental measure of inequality. Experiencing human development requires being alive in the first place. There is considerable discussion on inequality within India, particularly since the economic reforms of the 1990s. And this question is important from a health system priority perspective. So if the health system wants to reduce inequalities, on which people, where should it concentrate resources? A very standard approach: create an asset measure of household wealth. I create my own wealth index. I don't use the wealth index posted in the DHS surveys already, mainly because I want to exclude assets such as sanitation and solid fuel use that have direct links to health. And then I create discrete household wealth categories. So this is the first quantification of these disparities in India, and I'll get to the results right away. So life expectancy by wealth quartile for women at age 0, at age 15, and at age 60, and then for males. And then the blues are around NFHS 4 from 2012 and 16. And I combined the first two waves of the NFHS. They were smaller surveys. And then this is for a longer period, for 1990 till about 1999. In the more recent period, among women, life expectancy at birth among the poorest 25% by household wealth was 66.9 years, and then 73.8 years in the wealthiest quarter, a large difference. Disparities among men were even larger, more than 8 years. These disparities are even larger in the 1990s. So as life expectancy has improved in India, disparities have declined, but we should remember that these are still large disparities. We find disparities across the life course. So these are estimates of at age 15 and at age 60. There is some evidence of modest disparities among women, but among males, there are large disparities: 15.9 years at age 60 among the poorest quartile, and about 2 years more, slightly more than 2 years, more among the wealthiest men. Now you will say to me, okay, fine, these are quartiles. Maybe what if you did even finer categories? So this is a graph with ventiles. So Amartya Sen and Gendres, in their book An Uncertain Glory, say that India is part sub-Saharan Africa, part California. These are life expectancies for men from NFHS 4, so 2012-16. We do see sub-Saharan Africa levels of life expectancy. We don't see California levels among the richest 5%, but maybe if you did 1%, you would see some of that. And so you can also see that these are basically the full 95% confidence interval. You can also see that as you split the data, the confidence intervals become large, but they still allow for these estimates to be done reliably. Um, okay, we can do rural urban. The main point here in this graph is that for all quartiles, urban life expectancies are higher, but I was really surprised by the fact that disparities in urban areas are also larger. So let's look at men. So 60 in the more recent period from NFHS 4 in blue, 62 years among the poorest, and then 73 years. So a difference of 62.9, so 63, 73, 10 years. Um, so I took these graphs to Jerry and I said to Jerry, I am very surprised by the fact that even though urban life expectancies are higher, disparities are also higher. And Jerry was, no doubt, what are you? I guess when you have Jerry's experience, this doesn't surprise you any longer. We can do regional patterns to the extent that the data allows us. So the classic difference, South India, North India, it's worth noting. So these are national. These are the poorest 25% at the national level. And so if you're among the poorest quartile, and then if you live in South India and you're a woman, your life expectancy is about 72.9 years, which is higher than the wealthiest if you're a woman from the wealthiest quartile and if you live in some of these poorer North Indian states. The other thing worth noting is that within quartiles there is greater variation between India states for women than among men. I will move on and do robustness check. So you may say, well, you only did about 100 bootstraps. What if you did more? So partly it's a limit of my patience, and partly computing resources. You can definitely do more bootstraps, but this sort of should tell you that you won't change these estimates by a whole lot. So this is like the confidence interval for the poorest quartile of women from NFHS 4. So these, as you draw more samples, these do change a whole lot, but not after a point of time. So if you did more bootstraps, basically you don't expect these 95% confidence intervals to change all that much. Okay, so I've shown you life expectancies by wealth quartiles or ventiles, and then you may have read this piece by Angus Deaton in the International Journal of Epidemiology. So Angus Deaton is writing about social inequality, and so he says, in developing countries, other inequalities exert negative effects on health. Political inequalities, or the de facto or de jure disenfranchisement of some groups relative to others, prevents collective action in the interest of the disenfranchised and may slow down or prevent the construction of public health projects, even when economic growth provides the resources to do so. Income inequality is important, but other inequalities may play a larger role in population health. So with Nikhil, we document large and persistent life expectancy disparities among India's social groups. So we provide life expectancy estimates for Dalits or the lowest caste, or ex-untouchables, or what are called scheduled castes, Adivasis or indigenous peoples, or scheduled tribes. These are the two most marginalized social groups in India. Now there's the third category of other backward classes. These are middle class groups that were discriminated and marginalized, but they were not considered untouchable. And then high upper general caste groups, basically groups that are born with that have caste privilege and they're born into it. These groups are called scheduled castes because there's a schedule where they're listed, and so the castes that are listed in them are Dalits and Adivasis. And so this is a graph that is familiar. So this is life expectancy at age 0, 72 years among higher castes, and then 67 and 68 years. So a 4-year gap in 2013-16, an even larger gap among men. Now this gap is even more persistent across age and across time than wealth gaps. So at age 60, a difference 19 to 2-year gap among women, and even larger gap among men. Yeah. So so one thing to ask is what ages contribute to the gap, and we do an Arya decomposition. One way to look is to look at E15 or E60. Another is to say which ages contribute to the overall life expectancy gap at age 0. And so these are relative contributions. So ages, we see that the younger ages 0 to 5 contributed about 26% of the overall life expectancy gap, which is about the same. What is increased is the contribution of these older ages, 60 plus, so from about 30% to about 40%. So what this says is that if we care about the health of these marginalized peoples, not only should we, as we have traditionally focused on child mortality, we also need to focus on the health of older populations within these marginalized social groups. And some of the implications of this work. I have more results to show if you're interested from this, and I can talk about them in the Q&A. But one big picture implication, Dr. B.R. Ambedkar, the chief architect of the Indian Constitution, a Dalit leader, trained in Columbia and the London School of Economics, wrote in the 1950s, "The health of the untouchable is the care of nobody. Indeed, the death of an untouchable is regarded as a good riddance." About 60, 70 years later, we provide some quantification of the extent to which the health of untouchables is the care of nobody. Preston and Haynes, in their book, The Fatal Years, write in 1991 that the single most important variable in predicting child mortality levels, whether in the presence or in the absence of other variables, was race. Race was a caste-like status in 1900, and the degraded social and economic circumstances of Blacks, who had virtually no chance of entering the mainstream of American life, is undoubtedly reflected in their exceptionally high mortality. Within demography and outside it, there is a parallel conversation on race and caste. I see this literature as this paper as contributing to that literature. Okay. So now, if you're my friend Megan or my former flatmate Vikrant, you will say, well, caste doesn't function as you've shown us caste life expectancy disparities in caste group, but endogamous castes are actually jati. So what about, and there are in these jatis numbers in the thousands. So what about these finer caste categorizations? At the jati level, you will also ask, okay, what about regional differences? Pioneering Indian sociologist M.N. Srinivas recognized that caste mainly exists as a regional system. So if you think about the system of privilege and disadvantage, some of it is translatable across India, but most of it is local. And then you can also ask, okay, poorer groups, marginalized social groups are also poorer. So what about the intersection of social and economic disadvantages? So I've tried to answer I've tried to get at these questions, often unsuccessfully. So for instance, in 2019, I did a survey along with other student volunteers in rural Madhya Pradesh. So we did a census of 10 randomly selected villages. And then in the last 3 years, we observed about 700 households, 3,500 people, and about 100 deaths in the last year. So hardly anything to calculate jati life expectancies. But my hope is that we will be able to follow these villages over time and learn more about caste disparities and mortality in this sample. We don't have any jati mortality estimates from them. We do have cute photos. So until then, you will have to look at this. You may say, okay, fine, nothing from here. But what about places where mortality registration is complete? So along with Sneha, we have access to 2.8 million deaths registered in Kerala between 2006 and 2017. This graph shows that in the recent period, death registration in Kerala was very similar. Like the civil registration system and the census and the sample registration system were very close. So, and we also see that the civil registration system actually estimated reliable mortality estimates, especially when compared to the sample registration system. But the big problem is that the civil registration form in India, the death registration form, does not ask about caste status. This is surprising because there is often an administrative mandate to capture caste inequalities, and so, for instance, the census provides for the scheduled caste and scheduled tribes population estimate by caste. This is not available from the civil registration system right now. So, which brings me to the second part, which is explaining these gaps at a regional level in this paper with Sangeeta and Payal. So we use the annual health survey, which implemented a household death question. It was carried out by the Indian government. It visited 4 million households. So it is unlike the NFHS, which really breaks apart if you do state level estimation. The AHS is powered to do analysis at finer resolutions. It covered 20 million individuals in 9 of the poorest states in India. These states are representative of 50% of India's population. And I want to give a shout out to people who did really hard work in cleaning the AHS, my friends Diane Coffey and Sam Arenberg at UT Austin, but also people like Nazar who have at the Penn PSC who did significant work in understanding the AHS and cleaning it. The AHS did not ask Jati, but it allows state level estimation of social group disparities. Yeah. So right away, mandatory graph. Mortality rates from the AHS are reliable compared to the sample registration system. The NFHS rates are at the state level for a later period, and you can see. So, for instance, look at Jharkhand. The AHS is the only one that sort of provides what would be considered a reliable estimate of mortality that doesn't move around too much. And we can also do disparities in the AHS states. So we find similar evidence. Adivasis and Dalits have lower life expectancies. Now, the AHS has one problem, which is that it does not identify OBCs. So if it did, these high OBC estimates would be somewhere around here, and high castes would be somewhere around here. So think of these as a lower bound of or conservative estimates of disparities among privileged caste groups and Adivasis and Dalits. And then we can do state level estimates for Dalits and Adivasis. We see across states they have lower life expectancies than higher caste. This is female, and then this is male. For Muslims, we in some states we see higher life expectancies. There is so even though Muslims face significant social marginalization in India, there is past work of showing a mortality advantage in the childhood ages. We find that particularly because they're more likely to live close to each other, they're more likely to use toilets, and so they have less exposure. Children are exposed to a better disease environment. This is work, for instance, with Michelle Guo has contributed to, and which Dean Spears and Michael Caruso have shown this. We see that the mortality advantage among Muslims extends beyond the childhood ages in these data. And so fine. Now I can come to standardizing these by wealth. So here you see wealth deciles. And so this is the poorest decile, this is the wealthiest decile. Higher caste Hindus are more likely to be wealthier, Adivasis and Dalits, Adivasis in particular, more likely to be concentrated among the poorest wealth deciles. And then these are 95% confidence interval bars of life expectancy by wealth decile, by sex, by social group. We see significant disadvantage in the poorer deciles in these states, but also if you compare to these high caste groups here and here, also among these in the wealthiest categories. And then you can ask a standard demographic question what if marginalized groups had the same distribution of SES as higher castes? What would their life expectancy be? This is basically to estimate counterfactual life expectancies. This is similar to the standardization approach, except that it is implemented at an individual level and allows us to calculate standard error. So we have a reweighting function that is estimated for each individual, and then we reweight um, we reweight marginalized social groups to have the same distribution of SES as higher castes. So to have some intuitive understanding of this, so these are the poorest life expectancies among the poorest marginalized groups. These are this is the distribution. So what the reweighting standardization would do is it will downweight life expectancy estimates among these group to match. It will downweight these people and it will upweight these people. And so in the final estimate, these estimates will have a greater weight than these estimates in the reweighted estimates for Dalits and Adivasis. Yeah, and then we generate reweighted age-specific mortality rates and very similar, and calculate standard errors by using cluster bootstrap approach. We use three reweighting criteria: rural residence, asset deciles, and environmental factors. And this is what we find. So if you look at males, this is the raw gap between, so about 5 years among Dalits, slightly less among Adivasis, slightly less than 4 years um, among Dalits. When we account for rural residents, this gap doesn't reduce that much for Dalits, reduces slightly for Adivasis. When we account for economic status, it reduces some but remains. And when we account for environmental factors, these are the solid fuel use in the household, solid fuel use in the neighborhood, and sanitation, toilet use in the neighborhood. This doesn't reduce a whole lot. In fact, for Muslims, when we account for environmental factors, it increases slightly, which makes sense because these groups are more likely to use toilets. So if they were if they were less likely, the gaps would be higher. Okay, so these are the broad results that I want to share, and so it's time to go back to the original question and ask what are the strengths and limitations of the approach I just showed here. So some caveats. There may be common errors. So when I'm talking about the approach, what I mean is the household death question and estimates of life expectancy based on that. So common errors. So for instance, both the sample registration system and the NFHS may have some common errors, which we cannot discover because we don't have anything else to compare with. So think about neonatal mortality versus stillbirths. Now, both surveys don't do such a good job of distinguish mortality in the earlier ages. Now, there may be age misreporting. We know from work by Irma and co-authors that age misreporting, on average, biases mortality estimates. If there is higher age misreporting, mortality estimates would be biased downwards, and life expectancy estimates would be biased upwards. So marginalized social groups are more likely to have age misreporting. So if we accounted for age misreporting, disparities would be even higher. So we should think about these as conservative estimates. And of course, you need very large surveys and computing power to do this kind of analysis. But the big advantage is that these are available. So the SRS has monitored mortality, but it's just not available to researchers. These estimates are available and they're reliable. So we should use them to examine things that we're interested in. They're easier to implement. The household death question, especially compared to, say, the birth history module, is much shorter. They provide mortality across the life course. So compare these questions to, say, HRS or longitudinal studies. And for the first time, we can calculate life expectancy at age 0. And as I said, we can examine things that we're interested in. So to look forward to the Jati level estimates, as I say, disparities in causes of death We still don't understand, okay, what precise causes contribute to the Dalit high caste gap. And we know that cardiovascular disease is less prevalent among poorer groups, but things like chronic obstructive pulmonary disease, child mortality may be more prominent. These are just hypotheses right now, and it would be useful to examine differences in causes of death. Um Research that uses this mortality data, and of course, making available civil registration and sample registration data, and linking these determinants with that. And then understanding uh, better what these Hindu-Muslim differences are. The civil registration system actually does identify religion. So although Kerala is a more egalitarian context, Sneha and I are interested in doing this, and we also have some data on causes of death based on what it was reported on the death certificate. And then finally, actions that addresses these large disparities. For instance, among the urban poor, among women in North Indian states, among Dalits and Adivasis broadly. What we contribute, I think this work broadly is about the evolution of health disparities in the context of the epidemiological transition. And we have found research that has shown both the existence of inequality and not its existence in developing country contexts. So India is slightly different from these other contexts which don't show disparities in the adult ages. So India is kind of like this classic Lincoln-Phelan approach that even though the causes of death are changing, the mechanisms are changing, inequalities are persistent. We use really large data to document disparities across ages, periods, surveys, and place within India. And then I sometimes I worry that I only study one country, but India is a substantial part of the world. Its population is greater than that of Europe or North America combined, or all of Africa. So we now have a better understanding of health disparities in a place of consequence. And for some of the most marginalized populations on the planet, the population of Dalits is about 200 million, so about the size of Brazil. Adivasis are about 100 million, so together they're like the population of the United States. And for these really large groups that are really marginalized, we have some more evidence that contributes to a social conversation about the causes and consequences of caste disparities. Thank you.
Thank you so much, Aashish, for this very interesting presentation. Now we're going to start the Q&A part of the talk. We have several questions. I don't see any questions from our postdocs and doctoral students, so I would like to encourage you to raise your hands and ask questions. But I'll ask Herb to ask his questions. Herb, over to you.
Thanks. Aashish, can you hear me?
Yeah, I can hear you, Herb. Hi.
All right, well, listen, it was a really good talk. So, look, I've got a question, and then somebody asked something anonymously. These are just questions about standard errors, so let people ask about more important things. It's just as long as you're doing the bootstrapping, you've got the joint distributions, and you can do some, very accurate estimates of the estimated standard errors for differences and so on. But I'm going to stop and let people ask more substantive questions.
Okay. Herb, why don't you ask?
Yeah, so don't worry about it. I just wrote something down. You can take a look at these things later.
Okay. Thanks. Okay, thank you so much. Thanks.
Okay, thank you. Michelle.
Hi, Ashish. Thanks for sharing your results. Very interesting results. Very interesting talk. So I guess my question was about this, flatter gradients that can be expected in low-income countries, which is actually not what you find here. And I was wondering if you have some explanations about that. I mean, there is this idea that in low-income countries, SCS gradients in life expectancy should be flatter because of specific harmful health behaviors among high-income groups. In those contexts, while such as obesity, while obesity in a country like the US is more structured towards low-income groups. But you don't find this in India. So I was wondering whether you have any explanations whether those harmful health behaviors may not be so structured socioeconomically in the same way in India as in a country like Indonesia.
Yeah, I think so. A couple of responses. I think that's a great question and something I ask myself a lot. I have a couple of partial answers. One is that India is diverse. So when you're comparing SCS, you're also comparing places within India. So, I mean, you're comparing, say, people in Kerala to people in UP. But then you can still ask the question, so why do people in Kerala have better life expectancies at older ages than people in UP? And then I think the big answer, so one is this fine cardiovascular disease, but we haven't thought about other diseases very carefully in this discussions. For instance, exposure to pollution, to solid fuel use, which contributes to lung obstructions. COPD is supposedly the second biggest cause of death in India, and it is poor people are more likely to live in more polluted environments, even in rural areas. They are more likely to have their lungs obstructed, right? So that's one part of the explanation. The second, the second part is that there is accidental mortality and there is tuberculosis mortality, and I think these are still important drivers of health disparities among older populations in India. But so we don't have these causes. Sorry, go on.
Right. So just as a follow-up question, I mean, any plans to look at data on diabetes, obesity, and blood pressure, which I think are available in many of these surveys, and you could look at these gradients to try to inform a little bit more.
Right. There is some published work on this, but yes, I think when the longitudinal aging study of India comes out, when that data is available, this is one of the big questions to ask, right?
Mm-hmm. Thank you.
Thanks.
Thank you. Hans-Peter, you have a question.
This is very, very exciting. So you correctly pointed out that you don't need to kind of excuse yourself for focusing on one country, given both the size and diversity of India. But in this spirit, can you, these kind of health or life expectancy inequality that you observe in India, how would that compare to, say, inequality across Africa or some similarly sized populations?
Yeah, that's a great question. I think one thing is that I don't know how well we would be able to measure. So one open question is, does this approach work in countries in context outside India? This household death question, and then if it can be implemented within the demographic and health surveys, then we can have some estimates from Africa. I think existing evidence like your work, etc., points to some inequality within, but I would not. I think I wouldn't hazard a guess right now. I think, but it's an empirical question that is of consequence.
But even before you dig into these kind of detailed methods on which this research is based, I was thinking even simpler. So if you compare regional variation in, say, life expectancy or various mortality measures across compared to national variation, say, across Africa.
Right. Yeah, that's a good way to do it.
Similar diversity within India as you would get within Africa, or is India compared to the continent of Africa, which for sure is very heterogeneous.
Right.
Can you get less variation?
Right. Yeah, I think you're right about that. Yeah.
Okay, thank you. I have a question from Michael Lahansky. Michael?
Hi, this is related to the health behaviors. I was wondering if your survey information includes questions on smoking, and is there available information on water pollution in India or proxies? For instance, like, do you have ideas about which areas are more industrialized, which areas are more agricultural, that kind of thing? Thank you.
Yeah, thanks. That's a great question. So we do observe smoking and other health behaviors among the alive in the DHS in the population that is alive. We don't have these answers for the people who have died. So in some word that, so I think for these kinds of questions, what is most helpful are longitudinal follow-up studies. Although I did show the environment, in the extent to which environmental exposures and rural residence matters. So you could think that water or exposure to bad water is related to sanitation, and so that does not explain the gap between for life expectancy disparities among marginalized social groups and privileged social groups. So even though it's an important cause of death in India, sanitation and water, it doesn't explain gaps that we observe.
Well, I also wanted to point out that in the US, the effects of public health interventions in the 1910s and 1920s is now quite controversial. There's a lot of papers saying that there is no measurable effect. So even without focusing on necessarily the gaps between marginalized communities, even the main treatment effect of these kinds of public health interventions is up for debate in a US context. And I think some of these tools and surveys would be great to see a live case where you know that 25 years ago or 30 years ago, some of these health interventions were implemented in some regions and not others. You know, the difference design just jumps out at you. I just wanted to bring that up as a possibility. Thank you.
Right. Thanks. Yeah. Thanks.
Thank you. Next question is by Megan Reed. Megan.
Hi. I had a question. You were talking about the survival method and how some of the earlier evidence on it showed that it wasn't very reliable and it didn't match other estimates. So I was just wondering if you could talk a little bit about what you think changed such that now when you're doing these estimates with NFHS, you're getting more reliable estimates or estimates that match the SRS better. So I was wondering if you could talk a little bit about what's changed or what's different about your approach.
Right. So, so one thing is that the Indian DHSs are just larger than the average DHS. So earlier DHS rounds until 2005-06 were represented at the state level, and this one, the latest one, was represented at the district level. So so as surveys have become bigger within India, we see greater precision in these estimates. So for earlier rounds in the NFHS surveys, when you compare them to the SRS, age-specific mortality rates are still similar between the two rounds. What is different in the earlier rounds is you have wider confidence intervals. And now you have even shorter confidence intervals, even smaller confidence intervals in the newer rounds of the National Family Health Surveys.
Okay, thank you. So I have a question actually for you that is based on the quote that you provided in the middle of your presentation. I think it was a quote from the late 50s that the health of the untouchable is the care of nobody. And you show this very large discrepancies in health outcomes. So I'm just wondering if you could talk a little bit more about the policies that policymakers have in India or implementing in India to address these large differentials. So what is going on, and to which extent like local communities aware of this problematic? What is the role of these local communities, local leadership, and etc. to address the issue?
Right. Yeah, no, that's a great question. So India has fairly aggressive uh, s- uh, policies for affirmative action that are implemented much less aggressively. In theory, these policies could do some uh, could do more to could be better implemented. However, what these policies do is they tackle educational disparities or disparities in employment, and so we don't see similar focus on addressing inequalities in health, particularly among older populations. The other thing is that has happened is that in the recent past there is significant more emphasis on child and maternal mortality. So we see, so for instance, now uh, children from marginalized social groups in the latest National Family Health Survey are not less likely to be born in a hospital compared to privileged caste groups. So that has changed substantially. Even then, these disparities in child mortality and across the life course persist. So one thing that is would be really useful is a societal conversation about what contributes to these inequalities and what can we do about it. And so even the conversation on, say, child mortality does not think very carefully about caste, and there is a very little conversation about mortality at older ages. The groups that are most interested in having these conversations are the marginalized social groups, right? And there is significant, and so I think India is for about the last few years is having a national conversation about caste inequality. I think what we're trying to do is bring in health to this conversation on caste inequality as well.
Thank you. And just a follow-up question to this, just to make the link to the more recent epidemiological situation with COVID-19
Right.
in India, which
Right.
in India is very seriously affected. So
Right.
is there any evidence about inequalities and socioeconomic
Right.
differentials in
Right.
COVID-19 mortality and infection?
Right,
So,
right. No, I think that's a great question. So I think in the U.S. we've had these estimates, and they've had us. I mean, even making it to the presidential debate. In India, even basic things such as sex-specific and age-specific mortality is not available for a large number of states, and then from COVID-19, and then there is the other question about, so what about these social groups? And again, I think they are not available. We expect it to be in a certain direction, parallel to what I have shown. But it would be great if this data is made available. I do want um, related to this is that I have been surprised by the extent of monitoring of mortality by COVID-19. It is almost like we're getting real-time information, which in India we have never seen before on any mortality from any disease, right? So it's not the case that monitoring of mortality cannot improve in India. There is certainly capacity to do that.
yeah. Okay, thank you. And
Thanks.
we have time for one more question. And this is a question asked by anonymous attendee. So I'm going to read it to you. So the government of India claims that India is now open defecation free. How far is that true?
Yeah, we've shown some in 2018. We did a survey, and many states had the Indian government had claimed that almost everyone had toilets, and we showed that that is not the case. And I think there is a lot of accumulating evidence that that claim is not true in rural areas at all. I mean, you can even in urban areas you can step outside and you will realize that that is not true.
Okay.
I mean, Ileana, yeah, I mean, Hans Peter can also speak to this question from their own work. Yeah.
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 So I don't know if Hans Peter has anything to add to this. We have
No, I don't, but I agree.
Okay. Well, Aashish, thank you so much for this very interesting presentation. It was a pleasure having you here. I hope that our doctoral and postdoctoral students are motivated also to participate in the colloquium and present in the colloquium. Thank you all. Thank you very much for attending today's presentation. And just a reminder, we don't have a colloquium next week. We'll see each other on December 7th with a presentation of Cameron Campbell, who will connect from Hong Kong. And I wish you a happy Thanksgiving to all of you. Thank you so much.